Welcome, students, to Decode Healthcare with Harshal. If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. Now, today, we've reached a truly pivotal moment in our curriculum. We are diving into a high-stakes executive capstone focused entirely on overturning payer DRG downgrades. We're talking about complete denial lifecycle management, and honestly, this is where the rubber really meets the road in revenue cycle management.
But before we jump into the deep end, let's just look back for a quick second. You'll remember that in Part 143, we mastered Advanced Physician Advisor Integration, and we built this absolutely bulletproof Concurrent Clinical Documentation Improvement, or CDI, strategy. We figured out how to query physicians in real time, making sure the clinical picture perfectly matches the coding before the bill ever drops. But today, we are tackling the ultimate challenge. What on earth do we do when, despite all of our best efforts and picture-perfect documentation, the payer still denies the claim? Here is our executive syllabus for today. We'll be looking at 4 main pillars. First, the end-to-end denial lifecycle. Second, strategic appeal architecture. Third, contractual dispute resolution. And fourth, we'll wrap up with our capstone summary and a quick teaser for next time.
All right, let's kick things off with Section 1, the end-to-end denial lifecycle and root cause analysis.
So, you know the old saying, you can't fix what you can't track? The denial lifecycle officially starts the very second a claim is rejected or downgraded by the payer. This happens through the ingestion of electronic remittance advice. And notice the mechanism we're using here. We utilize the 835 CARC and ARC codes. These are the standardized codes that payers use to explain exactly why a claim was adjusted or outright denied. By tracking these specific codes, your revenue cycle team can immediately flag and categorize DRG downgrades the millisecond they hit the system, which stops the clock and lets us initiate our defense.
Now, these codes help us categorize the exact enemy we're facing. When we break down the major types of inpatient claims denials, we start seeing some very specific root causes. For instance, you'll see medical necessity, which is where a payer might claim that a short-stay admission should have just been classed as observation. Then there's insufficient documentation. Maybe the operative notes or the present-on-admission indicators were just missing. And of course, there are coding errors, where misaligned ICD-10 codes or DRGs trigger a rejection. Figuring out which bucket your denial falls into is absolutely crucial because it dictates your entire appeal strategy.
Broadly speaking, these root causes generally fall into 2 massive categories. On one side, we have clinical validation denials. Think of this as surgical precision by the payer. They agree the patient needed to be in the hospital, sure, but they are trying to drop a specific, high-paying complication or comorbidity, a CC or MCC diagnosis, like acute kidney injury or sepsis. They'll claim the clinical indicators just don't support it. On the flip side, we have inpatient level of care denials. Now, this is more of a blunt instrument. Here, the payer denies the entire inpatient stay based on broad medical necessity, basically arguing the patient could have easily been treated in a lower care setting. So, the crucial point for us is how we actually measure our success in fighting these off. As an executive, you need a denial management dashboard tracking all of this financial leakage. You have to meticulously weigh your net overturn rate. Basically, how many of these denials are you actually beating? And you have to compare your cost to appeal against your total recovered revenue. I mean, think about it. If it costs you $1,000 in administrative time just to fight for a $500 DRG variance, you are losing money even when you win. This dashboard really has to be your financial compass.
Moving right along to Section 2, strategic appeal architecture and evidence synthesis.
Okay, now that we've identified the root cause of the financial leak, it's time to build our defense. And you really have to understand that appealing a denial isn't just a one-and-done event. It's an entire multi-level escalation pathway. Step 1 is the initial reconsideration, which is essentially just asking the payer to take a second look. Now, if they refuse, we escalate to Step 2, an external independent review, which is often handled by a qualified independent contractor, or QIC. And if the clinical truth is still somehow being ignored, we take it all the way up to Step 3, an administrative law judge, or ALJ hearing. It's a ladder of escalation, and you've got to be prepared to climb the whole thing.
To actually win at any of those levels, you need what I like to call the unbeatable clinical appeal dossier. We aren't just writing a quick letter saying, hey, please pay us. We are synthesizing hard, objective data. We're pulling physician progress notes, the medication administration record, vital sign trends, and laboratory trajectories. Then we integrate authoritative clinical consensus guidelines, things like the Sepsis 3 criteria, KDIGO for kidney injury, or ASPEN for malnutrition. And finally, we cross-reference all of that with the official ICD-10 coding guidelines and AHA coding clinic advice. We are basically building an undeniable fortress of clinical and coding truth.
Which brings us to the actual drafting of the appeal itself. Notice the meticulous structure that's required here. You identify the reason, compile your documentation, and then you draft a highly structured letter. A really vital tactic to use here is citing legal precedents. We have to make it explicitly clear that it's strictly prohibited for payer auditors to substitute their own retrospective, proprietary algorithms for the actual treating provider's bedside clinical judgment. If the physician documented acute respiratory failure based on the patient's presentation right there in that moment, a payer's algorithm running 6 months later cannot simply erase that reality.
Let's move into Section 3, Contractual Dispute Resolution and Payer Accountability. So what happens when you present that unbeatable dossier and the payer just stonewalls you? We have to ask this critical question. What happens when payers act in bad faith? When they just repeatedly ignore overwhelming clinical evidence simply to hold on to the funds? Well, this is where we move past standard appeals and dive straight into commercial payer contract enforcement. We must strictly enforce the contractually agreed upon clinical definitions, aggressively police their audit look-back windows, and hold them tightly to technical denial appeal timeframes. If they miss a deadline, there's no leeway, we hold them accountable.
When lower-level appeals stall out due to that kind of bad faith behavior, we have to execute aggressive escalation strategies. First, we engage legal counsel to review for breach of contract. Second, we utilize state insurance commissioner dispute processes to flag a documented pattern of unfair practices. And third, we conduct executive-level peer-to-peer payer settlement negotiations. Believe me, sometimes it literally takes the chief financial officer of the hospital sitting directly across a table from the medical director of the payer to force real accountability.
But listen, winning the appeal is only half the battle. The denial life cycle is not fully complete until we establish loop-closing feedback pathways. Every single time we get a denial, even if we ultimately win the appeal, we absolutely must feed that trend data directly back to our CDI, Health Information Management, and Clinical Operations teams. If payers keep denying our acute MI claims because the discharge summaries are just too vague, we have to educate our physicians to prevent those recurrent documentation vulnerabilities in the future. We learn, we adapt, and we close the loop.
And finally, let's wrap up with Section 4, our capstone summary and teaser. We have covered an immense amount of ground today on how to protect the integrity of our hospital's revenue. Just to quickly recap our overarching themes. First, we mastered tracking the end-to-end denial lifecycle using ERA and root cause analysis. Second, we engineered the construction of that undeniable multi-level clinical appeal dossier, combining solid clinical guidelines with coding rules. And third, we laid out the heavy artillery, executing commercial contract enforcement and executive escalation strategies to ensure total payer accountability.
Up next, in Part 145, we are going to take everything we've learned so far and apply it to health system CMI optimization, risk adjustment, and value-based bundles. As we close out today's session, I want to leave you with one provocative thought to chew on. Aggressive denial management isn't just about the money. It's actually about fiercely protecting the true clinical narrative of your patients. When a payer downgrades a claim, they are essentially rewriting your patient's medical history. It is our absolute duty to defend the truth of the care that was provided. If you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Thanks for tuning in, and I'll see you in the next lesson.